With osteoarthritis, the cartilage, which is the smooth, rubbery tissue that covers the end of the bones where they form joints, breaks down. This exposes bones, causing them to rub together. It's like losing the cushioning in your favorite sneakers, leading to pain and stiffness. Now, let's delve deeper into finer details. Before we start, let's look at the articular hyaline cartilage composition in healthy synovial joints. Here, it's mainly composed of water, type 2 collagen, and proteoglycans. The pathophysiology of osteoarthritis involves three main processes: mechanical wear and tear. Overuse and aging leads to degeneration of cartilage. Imagine cartilage as the cushion in your joints. Overuse or due to injury, this cushion wears down, causing bones to rub against each other. Joint inflammation. Stress to cartilage leads to cartilage degeneration. The synovium, a membrane lining the joint, becomes activated in response to cartilage degradation products. Activated synovial cells, which are known as synoviocytes, stimulate synovial inflammation and the production of pro-inflammatory cytokines such as interleukin-1 and TNF-alpha. Inflammatory cell infiltration. Macrophages, T cells, and B cells infiltrate the synovium, contributing to the inflammatory environment. These cells further release cytokines and chemokines, perpetuating the inflammation. Excess synovial fluid. Inflammation leads to increased production of synovial fluid, which causes joint swelling and pain. This is also referred to as synovitis, meaning synovial inflammation. Cartilage degradation also leads to chondrocyte proliferation and activation. Let's look at chondrocytes. Chondrocytes are normally responsible for maintaining the cartilage matrix, which includes producing and regulating the extracellular matrix components such as collagen and proteoglycans. Chondrocytes respond to cytokines like interleukin-1 and TNF-alpha by producing matrix metalloproteinase enzymes and aggreganesis, which cause the degradation of the cartilage extracellular matrix. Pro-inflammatory cytokines induce apoptosis, which is a programmed cell death of chondrocytes. This loss of chondrocytes impairs the cartilage repair mechanisms, accelerating the cartilage degradation. As a result, the cartilage loses its structural integrity and cushioning properties. Let's look at the cytokines once again. Interleukin-1. Interleukin-1 is a critical mediator in osteoarthritis. It is produced by activated synovial cells and chondrocytes, and a lot of other cells, but we will talk about it in a future video. Interleukin-1 stimulates the production of matrix metalloproteinases, which degrade cartilage. It also promotes the synthesis of other pro-inflammatory cytokines. It inhibits the synthesis of type 2 collagen and proteoglycans, which are essential components of cartilage. Tumor necrosis factor alpha. This is another key pro-inflammatory cytokine which is involved in osteoarthritis. Similar to interleukin-1, it induces the production of metalloproteinases. It enhances the expression of adhesion molecules, facilitating the recruitment of inflammatory cells to the joint. It inhibits the synthesis of cartilage matrix components. Interleukin-1 and TNF-alpha stimulate the osteoclast activity, leading to increased bone reabsorption and remodeling, which we will talk about later. Let's look at the word osteoclast. Osteon comes from Greek and means bone. Clastos, which also comes from Greek, means to break down or destruct. It is found in words like iconoclast, which is a person who destroys religious images or opposes their veneration. Pyroclastic, related to fragments of rock erupted by a volcano. The ongoing cartilage degradation further activates the synovial cells and chondrocytes. This creates a vicious cycle of inflammation and degradation, which exacerbates the joint damage and symptoms. Structural degeneration. Proteoglycans in healthy tissues help retain water and maintain the elasticity of the cartilage, providing resilience to decompressive forces. In osteoarthritis, there is reduction in proteoglycan content within the cartilage matrix. Because of this, we see loss of water retention. The cartilage becomes less capable of retaining water, leading to dehydration and loss of elasticity. Susceptibility to damage. Dehydrated cartilage is more prone to wear and tear, leading to the formation of microfissures. Edema and microfissures. The initial damage progresses to more significant structural damage. resulting in edema within the cartilage and the development of subchondral cysts and erosions. Bone changes. Osteoclasts are responsible for bone reabsorption, a normal part of bone remodeling. Osteoclasts break down the old or damaged bone tissue, which is then replaced by new bone formed by osteoblasts. In earlier stages of osteoarthritis, there is increased activity of osteoclasts in the subchondral bone, which is the layer of bone just below the cartilage. This is due to the interleukin-1 and TNF-alpha, which was previously released by chondrocytes and synovial cells, as they also stimulate the osteoclast activity. This process leads to increased bone reabsorption, which in turn leads to the breakdown of existing subchondral bone. This reabsorption creates microdamage and cavities in the bone which need to be repaired. In response to the microdamage and increased reabsorption, there is a compensatory increase in osteoblast activity to repair and remodel the damaged bone. Osteoblasts in the healthy bone are responsible for formation of new bone tissue, and they promote the bone matrix and facilitate the mineralization, which ensures bone strength and integrity. In response to the increased reabsorption activity of osteoclasts, osteoblasts increase their activity to repair and remodel the damaged bone. This leads to subchondral bone sclerosis, which is a compensatory bone formation that leads to hardening and thickening of the subchondral bone. This process is known as sclerosis. This extra bone growth results in the formation of osteophytes or bone spurs, which are the bony projections that extend from the normal bone. They lead to more pain and swelling. The increased density and rigidity of the subchondral bone can lead to the formation of small cracks or microfissures. Synovial fluid, which lubricates the joint, can seep into these microfractures, accumulating and forming fluid-filled sacs within the bones. Over time, these fluid-filled sacs enlarge, resulting in the development of bone cysts. The friction and inflammation which happens here leads to decreased range of motion and significant discomfort, impacting daily activities. Let's look at the pain mechanisms. Cartilage is aneural. Therefore, the pain arises from inflammatory mediators which cause intra-articular hypertension, capsular distension, and stimulation of synovial and subchondral bone nerve fibers. Associated conditions. Concomitant enthesiopathy or bursitis may also contribute to pain. Enthesiopathy is the inflammation at the sites where tendons or ligaments attach to the bone, called entheses, which contribute to the pain. Bursitis. Inflammation of bursa, which are the small fluid-filled sacs that cushion bones, tendons, and muscles, can also lead to pain. Muscle weakness. Altered joint use leads to muscle weakness and atrophy. Let's look at the anatomical changes. Early changes. Minor cartilage wear causes mild pain and stiffness. Here, articular cartilage damage happens, which includes surface fibrillation, where the cartilage surface becomes frayed and irregularity, where we find loss of smoothness, which leads to uneven joint surfaces, and focalized erosions, where localized areas where the cartilage is worn off exposes the bone underneath. Advanced changes. Significant cartilage breakdown leads to bone friction, severe pain, inflammation, and restricted movement. Osteophytes, known as bone spurs, also form, and subchondral bone becomes thicker and sclerotic. Bone cyst formation and episodic synovitis also occurs. Let's look at the histological changes. Early histological changes. Loss of proteoglycans disrupts the cartilage fibers, leading to cartilage softening and increased water content. Chondral fibrillation, cracks, and fissures appear. Later changes. Fibroblasts fill the area of cartilage loss, forming a pannus. Remodeled matrix can become calcified and invaded by small vessels later in the disease. End stage changes. Bone spurs form and bone cysts appear, filled with inflammatory fluid, myxoid material, or bone fragments.